Now over to Mrinal for examination of cervical spine.
It's not a very didactic kind of presentation, let me warn you, because at the end of the day you have to learn yourself, and the only way to do is to see more and more patients. In the last line of Superno's lecture was that we should have a custom-made solution for all the patients. And it is very important in our MSK practice, because what we usually see is that the moment a patient puts his hand here and then runs down, gets an MRI, isn't it? You just have to just swipe his hands here, and then before you even examine, you just write, okay, MRI cervical spine. Okay? Now let me tell you, it's less than 10% of the people who come to you for back pain or neck pain actually have a neurological problem. 90% of them don't have. But unfortunately, eyes see what mind knows. Okay? So let me take you a bit of a different kind of journey in our usual practice. So I'll take you back to basics. Okay? And then we'll go from there. So we know about cervical spine. So 7 top vertebrae out of the 33 that we have. And then these are the typical vertebrae. And you have atlas, okay, anterior tubercle, LR ligament. Do we have a pointer? Okay. Sorry. All right. Ye wala, theek hai, okay. So these are the LR ligament, this is the cruciate ligament, then we have an apical ligament. So these are very important to know because this is typical vertebra, 1, 2 and 7. These are typical vertebrae. And then we have here the dens or the odontoid and the articular facets. This is for the occiput, and I'll show you more photographs. And then it's more of a pictorial journey. Then we have a typical thing here, which is transverse foramen, and these are again the facet. And here we have the lamina, the pedicle, the anterior and the posterior tubercle. These are the things that we have to remember. Here we have atlanto-occipital joint. The occipital actually sits on C1 and the C1 sits on C2, the atlanto-axial joint. And then here we have dens, which is articulating with the posterior surface of the anterior arch of the C1. And here the posterior facet is where you have your cruciate ligament. Okay. Can anybody tell me how many muscles are there in the anterior compartment of neck? Anybody? Just a number. Probably no one knows it. And then it becomes important because there are so many other pain generators. It is not the root only. There are so many other pain generators. So these are the anterior neck muscle, the platysma, sternomastoid. Then we have suprahyoid, okay, DSMG, digastric, stylohyoid, mylohyoid, geniohyoid. And then we have infrahyoid, okay, sternothyrohyoid. And then we have anterior vertebral muscles, the rectus capitis anterior, lateral longus capitis, and longus coeli. So these are the anterior muscles. Any of them can be a pain generator. Okay. So this is our platysma. Okay. I won't go into details on all these muscles. I just want to leave you with a picture in your mind. Okay. So that you don't think MRI all the time. Okay. Then you have sternomastoid with its 2 head. Okay. Sternal and clavicular. Then this muscle, anybody? Which is this muscle? Right, digastric. Good. Which is this one? Mylohyoid, the floor of the mouth. Okay? Then geniohyoid. Okay? Omohyoid actually goes from the scapula. This is stylohyoid. Okay? From the styloid process to the hyoid bone. And it helps to move the hyoid bone, as our previous speaker who was teaching about swallowing So they are very important because during swallowing you have to move your hyoid. Okay. Then we have sternohyoid. Sternum to hyoid. Then this is our sternothyroid. Runs to thyroid. Okay. This is this is thyrohyoid. This is omohyoid. Okay. It goes from hyoid to the superior surface of the scapula. Okay. And it is an important muscle. Then we have rectus capitis anterior. Then we have rectus capitis lateralis. Okay. And then we have longus capitis. And then we have longus coli. All these muscles become important if you want to do interventions for cervical dystonia. Okay, because these muscles are very important, very small, and they have all the important structures around them, and you have to do an ultrasound guided botulinum toxin injection into them. And if you follow the principle of Karl Kaput concept, anybody aware of Karl Kaput concept of cervical dystonia? No? This is the message I want to give you. Okay, because you need to know these muscles if you want to do it. Okay, but these are only anterior muscles. Then we have lateral muscles. Okay, the scalenes, the anterior, middle, and the posterior scalene. We actually had a very interesting patient. There was this lady. I think this month. We saw it last month actually. This was a lady with a pain in her neck radiating to arm. Okay. And then this lady was actually referred from cardiothoracic surgery. Previously, she was thought to have a vascular problem in the hand. And she was about to be operated. They did an angio and they found out there is no subclavian steal syndrome or no thoracic outlet. So then she was referred to us. And then we also saw her MRIs and whatnot. All the investigations were already there. And then we thought it's a very, very bad pain with myofascial pain, cervical myofascial pain. And she's better than what she was before, but still I think we need one more muscle, and we did, I think, Botox for her. And I was not very comfortable doing a Botox for these anterior strap muscles, which was one of the pain generator. And we are going to do it as soon as we finish these conferences. And then that is how it becomes important. And she's now okay. I think 70-80% she's okay. And hopefully once we inject the strap, she will be totally pain-free. Imagine she was under cardiothoracic surgery for subclavian steal syndrome. So this is the kind of journey you will have with your patients. So you have anterior scalene, and let me tell you, scalene is one of the very common muscle for neck pain. Okay. Then you have middle scalene, then the posterior scalene, which actually comes from the second rib. Okay, coming to the posterior part of the neck now. Okay, the biggest muscle that you know, trapezius. Okay, let me tell you my own story. I had a very, very bad trapezius myofascial pain, and people who know me, how I have gone through that torture almost a year. And actually, this is not joke. I actually had to read about it. And then I found that I probably have spinal accessory now, entrapment in my trapezius. And then I contacted one radiologist and I had to convince him. And then I showed all the articles to him that this is the way you have to do hydrodissection of a spinal accessory nerve for me. And then I'm 95% better after doing that block. And everybody was thinking otherwise, even my physicians and surgeons and whatnot. So it's an interesting thing, okay? And I'll share the article if you are interested. Okay, and you have a patient to examine also. I'm there. All right. Then we have splenius capitis. Very important muscle, not only for pain, but also for dystonia. Okay. Then we have splenius cervicis, because it is going to the cervical spine. Then we have the deep layer. There are 4 layers. Okay, superficial layer. Deep layer is semispinalis capitis, cervicis, and multifidus. Multifidus is the most important muscle and the cause of back pain in more than 45% of the cases. So if you understand it, people will become better without spending a penny on any kind of investigation. So semispinalis capitis, then semispinalis cervicis, and multifidus. Okay, it runs through whole of the spine. Then we have deepest layer, or the suboccipital. These are very small muscle, probably required to do intervention only when you have a caput problem in dystonia. Okay, when your head is tilted, not the spine. So caput is when your head is tilted. Okay, the deepest layer. I'll just go on the muscles. So rectus capitis, posterior major, then rectus capitis, posterior minor, then obliquus capitis, inferior, and what you can see on up connected is the superior. Okay, and then we have 2 more muscles. One is interspinalis cervicis, and this is intertransversi coli, which runs through the anterior and the posterior tubercle. All right. Then other important thing I want to tell you is, this is our anterior longitudinal ligament. It goes up to here, and after that what you have is anterior atlanto-occipital membrane. Okay, and posteriorly you have this what you call as nuchal ligament, and here you have posterior atlantoaxial membrane. Okay, there is no posterior longitudinal ligament there. All right. This is one more diagram. Here you can really appreciate the cruciate ligament, the LR ligament, and you can't see there is one going up from the tip, which is the apical ligament. Okay, very important if you are looking at the trauma and the movement of the odontoid and all those things. I think we had a little bit of the cervical spine trauma in the midterm CME with just in Delhi a couple of days before. Very important. This thing, which is running from here, going through here, C6, and going up to C1. The vertebral artery, very tortuous path. Okay, responsible for dizziness, dropouts, dizziness, vertigo, nausea, vertebrobasilar insufficiency. Very important. Other thing that you have to remember are these joints of Lashka. Okay, this is uncinate process, also called as uncus, and the upper part is called as echinoceri. Then again, back into anatomy, look at this. The angle of the cervical spine, the facet joints, also we call as facet is the what American people call it. But after Trump, I think I will not speak of facet. I will speak of zygoepiphyseal joints. Okay, all right. So we have this 45-degree angle of cervical spine. Okay, and then again, very important. It's important photographs. This is the Rafford area of the facet joint. Okay. So if you have a facet joint problem, C5, C6, this is the area. Okay, then this is C3, C4, this is C2, C3, C4, C5, C6, C7. Okay, so this is the Rafford pain. The pain generator is actually the facet joint. Okay, similarly the same kind of diagram. So people will always put their hand, यहाँ बहुत दर्द होता है, probably because of C2, C3. Pain happening on the top of the head, very common in old age because of C1, C2 arthritis. Okay, and then we all know we have C7, 7 vertebrae, but 8 roots. Now the common symptoms are anesthesia, ataxia, atrophy, drop attack. You have to differentiate between drop attack and syncope. Anybody? Difference between syncope and drop attack. What happens is patient just stands and falls. Tuck. What is that? Syncope or drop attack? Syncope is something where you don't forget, when you forget the event. But drop attack happens when you're awake. And it happens because of vertebrobasilar insufficiency. Okay, we have seen people who had nothing, only hypoplastic vertebral artery. And because of that, she was getting dizziness. Okay, so you have to really suspicious about it. So dysesthesia, falling, fasciculation, hyperesthesia, nystagmus, pathological reflexes and all these things, tenderness, spasticity and everything else. All right. Now history is very important. All the investigation that you have in the world cannot replace a good history and physical examination. Okay? So whenever you have a patient and you have symptoms, what is the age of the patient? Okay? If you have a child, say if you have a child, 7-year-old, okay, with knee pain, cough and fever, I will not wait for x-rays. I will immediately go for MRI. Septic arthritis, the most common diagnosis. But if you have a 60-year-old person with no fever, a bit of pain, difficult to getting up, you can get an x-ray if you want, but you'll be right if you say it's osteoarthritis. So age becomes important. Similarly for neck pain also. Because as the age goes up, you have more degenerative changes. You'll have stenosis, myelopathy, facet arthropathies and arthritis and whatnot. Okay? Then the symptoms. What are the symptoms? Do they vary? Okay? So say you have a painter and then he presents to you, "Sab chakkar aate hain." Kab aate hain? So whenever I go to work, I always have chakkar. I cannot work. So what actually happens? He's a painter. He gets on a ladder, goes into extension, it starts painting. So when he does an extension, he has a vertebral artery insufficiency, gets a dizziness, has to get down, otherwise he will fall. Okay, so that makes important. What is the variation? When does it happen? In the same case, he can say, it happens only when I go for work. It never happens at my home, because he is never working at home, isn't it? Okay, so similarly, is it intermittent or is it variable? What are the factors? How it becomes better? I have a very bad pain, neck pain, arm pain, but when I take my hand up, I feel better. What is this sign? I'll come to that. Okay, I'll show you. All right. Then mechanism of injury. Okay, so if you have a lady with a very bad back pain, dizziness, nausea, rhinorrhea, you said, what happened? So I was riding as a pillion on a motorcycle with my husband and somebody hit us from back. And since that day I'm having this bad neck pain. So what she has is, see, so many patients. That is what I was saying. You have, your eyes see what mind knows. It's a whiplash with hypertonic sympathetic system. Okay, so the mechanism of injury becomes important. And that is the reason you have that neck support in your car, to prevent you to get whiplash injuries. Okay, all right. Then you can have burners and stingers, the brachial plexus. We don't play rugby here. We all have RTA, that to us. But if you are a rugby player or a kushti player, you will have burners and stingers. Okay, and then kids comes nowadays with very bad neck pain, cervical myofascial pain or whatever pain. So then you ask her, कैसे पढ़ाई करती है? घर पे कैसे पढ़ती है? And she actually uses a mobile, lies on the bed and attends all the lectures on that mobile. So if you are lying down like this for 4 hours every day, you're going to have a neck pain anyway, isn't it? So that becomes important. What is your usual pastime? And then the upper cervical symptoms, or have you seen those people sitting in the offices on their computers? Poking chin syndrome, what you call as upper torso syndrome. Read about it. I will not go into details of that. So upper torso syndrome, very common nowadays. Everybody is on computer and iPads and whatnot. All right. So was the onset sudden or insidious? What are the sites? What are the boundaries? Where it radiates? Where that pain is going? What is the variation? Any diurnal variation? No, sir, pain happens only at night when I am actually doing rest. Night-time pains, night sweats, dangerous things. What it can be? Anybody? POTS. That's what will come in your mind, isn't it? POTS spine. Okay? Is there associated headaches? Okay? It is very important to differentiate about headaches. So we'll talk someday, some other day, because it can be some devastating clinical entity, or it can be just a simple cluster headache. Paresthesia. Any lower limb symptoms? Poor balance, and probably he has a compressive myelopathy. Okay? Then difficulty in walking and all those things. All right. Okay? So it becomes important about dizziness, faintness, drop attacks and all those things which we have already talked about. Now if you look at this fracture, so some minor trauma, maybe ankylosing spondylitis, particularly when you are looking at cervical trauma, okay? Most of them will have a central cord-like picture. Neoplasm, it becomes worse at night. Okay, is there any previous history of cancer, infection? And I'll share one of the patient that I saw had a neck pain and arm pain. Okay, and he had all kinds of investigation done. Okay, and the only problem was that he said the abduction of shoulder causes pain. I couldn't find anything on X-ray. Is this for 50-year-old gentleman? And then ultimately we got an MRI done for the shoulder. So there was this a kind of a bone cyst lesion in the head of the humerus. Okay, and he was later found to have a CA lung with metastasis everywhere. Okay, so that was the point of presentation. All right. So infection will have fever, chills, night sweats, and all those things. And so these are the things that we have to know, because these are the symptoms which will turn our path. Hoffman's reflex, then occipital headaches and numbness. So these are the different features of different problems that we have. And we have to keep the symptoms in our mind. Again, headaches are common. Migraine is not that common, but cervical headaches are common. Okay? And if you have occipital or suboccipital component to an headache, it gives you a direction, it is because of your neck. The neck movements alter headache, painful limitation of neck movements, abnormal posture, tenderness in suboccipital region. It can be occipital neuralgia, abnormal mobility of COC1, sensory abnormalities around the occipital and suboccipital region. So we have to observe how is the patient looking. What is the attitude, how they are sitting, how they are behaving. Even people who have catastrophization, okay, they have a different kind of behavior when they come into your OPD. Or they have this phobia, what we call as kinesiophobia, fear of movement, which are bad prognostic sign in any of the pain patient. Okay, so you read about it. All right. So how is the neck posture? What are the shoulder levels? Or if you have a small neck, a kid, young man with a small neck, probably spasm, torticollis, Klippel-Feil syndrome, what it is, we have to just keep that mind active. Okay? Then we check the ROM, the active and the passive ROM. Okay? Both the ROMs we have to check. All right? So many times, I think every day I see 2-3 patients who actually had a frozen shoulder but instead had an MRI of neck done because they never bothered to lift the arm. Okay, so if you have a frozen shoulder, you will have stiff trapezius anyway. Then goniometry. I have not shown you all the diagrams, but the message is you should actually examine the range of the movement. All right, and what you see here is the inclinometer. Okay, if you are interested, you can buy it. It will cost you, I think, 10,000 rupees. All right. So examination, we have to check the resisted isometric to check at the strength of the muscles. Okay. Then we have to do a very scanning examination of the peripheral joint. If you have gone through Apley's says you have to always examine two joints, one above and one below. All right. So we have to follow that rule. So TMJ joint, shoulder joint, elbow joint, wrist and hand, all these things we have to examine, because where will the weakness happen? It will happen in your upper limb. All right. Then we have the dermatomes. All of us know about it. This is the other important diagram that you should know. All right. So this is the sensory nerve distribution of head and neck. All right. So this is the ophthalmic nerve, the maxillary nerve, the mandibular nerve, then the transverse cutaneous nerve of neck, the dorsal rami, and then the suprascapular. So this is also important. Okay, keep in mind. All right. Then the cervical myotomes. Everybody just, I think, revised it. Coming to the spatial test, the distraction test. So if you have a foraminal compression, the moment you have distraction, the patient will feel better. But let me tell you, you have to basically make a conclusion after doing all of it. There is not a single test which has 100% of specificity and sensitivity. Okay? So these are the different tests that will take you to a meaningful pathway. Then we have foraminal compression test. So there are actually three types of spurling. Okay? One is this, side bending. Another is side bending with extension. And the third is side bending with extension with rotation. Spurling 1, spurling 2, spurling 3. Okay? Sign of cervical radiculitis or a radiculopathy. All right. Jackson compression test, again for compressive radiculopathy. All right. Can be positive in myelopathy also. This is shoulder abduction test. So patient gets relieved once you put your hand on the head, also called as Bacod's sign. Okay, this is again a sign for cervical radiculopathy, because when your arm is hanging, what is happening? It is stretching the brachial plexus. But the moment I do this, it gets relaxed. Pain goes away. More than 90% sensitivity and specificity to have a radiculitis. All right. Most of the times patient actually come like this in your OPD. All right. Then this is not very specific, but it is interesting. So you basically turn the head, little bit of side bending, and you do a Tinel's test here. Sorry. All right. So to see if the Tinel's is positive. All right. This is very important, which usually they don't teach us. Okay. This is upper limb neurodynamic testing. Okay. These are the tests, and these are also therapeutic exercises for your carpal tunnel syndrome, for your cervical radiculopathy, compressive cervical radiculopathy, for your foraminal compromise. Okay, this is ULNT1. So basically you can see the shoulder abduction, shoulder depression, making everything straight and doing the extension. This is basically for median nerve and anterior interosseous nerve irritation test. Okay, then the B1, oh this one, okay, this one is for the radial nerve, this is for the median nerve with axillary, and this one is for the ulnar nerve. So if somebody is interested, they can actually look for it. It is there on the net. There is video also. Everything is there. Valsalva test. We tell patient to do Valsalva maneuver. It triggers the symptoms. That means it is probably something which is compressing inside. All right. Can be radiculitis or a tumor or a myelopathy. Then we all know Lhermitte's sign that is there. Then Romberg's sign. Many times we get confused. Romberg's is basically for sensory ataxia. It is not for cerebral ataxia. All right. Then this is a vascular sign for vertebrobasilar insufficiency, also called as Horn's test. So we tell the patient to keep both of hands supinated, and we do this side bending and extension. Keep her into it for at least 10 to 20 seconds, and she will have dizziness or probably will fall if she has vertebrobasilar insufficiency. Similarly, we can also do in a lying down position. Okay, turn the head into extension and then stretch. All right. Then, but we have to differentiate, because another common thing that we usually see is BPPV. Okay, benign paroxysmal positional vertigo. It is not very specific, but still it works. The Hall-Pike-Dix maneuver. Okay, so long leg sitting, turn to 35-40 degree, and then you suddenly take the head down from the plane of the bed. Okay, then reflexes we all know. Then Rafford pain of the muscle. If you want to do MSK practice, you must read about it. Okay, the Trigger Point book. I don't know who was I forgot who is the author. Who is that author of that book? Huh? Travel and Simons. Okay, so that is very important. Then you will find out most of your patients are actually from that book instead of what you're thinking. All right. Then palpation. Okay, so you can actually palpate all the facet joints if you have a thin man with you. Then this is my second last. I won't go into any detail about X-rays and the MRIs and the CTs and all the McGregor lines and all those things. Probably some other class. It is very important that we have low radiations. I don't know if you have observed, the number of patients with cancer is increasing every day. Unfortunately, you will find one or the other in your family or friend to have this problem. Okay, so be very careful if you are ordering X-rays, because every X-ray is an ionizing radiation. So you order X-rays and CTs when it is really required. Even though I will actually accept that we overuse CTs in our emergencies and acute patients. All right, we do some. I think the average CTs that we get done in spinal injury patients in a single patient is 3 CTs. Okay. And each and every CT scan is equivalent to 400 X-rays. So you get 3 CTs done, it's 1200 X-ray in a single day. Okay, so there is no wonder if you get cancer probably after 10 or 15 years. So very careful about that. That's why we have Nix's criteria. All right, so if you have a trauma, if you have all the 5 criteria, there is no need for an X-ray. All right, then these are Canadian C-spine rule. Okay, so if there is any high risk factor like dangerous mechanism more than 65, get an X-ray done, or any low risk factor which allows for it, then there is no. If yes, then able to actively rotate, and there is nothing there is no need for an X-ray. It is there on the net. It's called as Canadian C-spine rule. Okay, always follow it. And my last slide. These are basically important views that we are interested in. AP lateral open mouth when we want to look at C1, C2. 45 degree oblique view if we are interested in to look into the facet joints. Then lateral view and flexion extension if we want to see the osteophytes and the canal diameter. Okay, you find out if you have a good X-ray and if you can find the ratio of the width of the vertebral body and from the posterior wall of the vertebral body to the lamina. If the distance goes less in the posterior aspect, probably this patient is a cervical spinal stenosis. So you can diagnose on X-ray also if you have good X-ray. Then if you are not able to see the lower portion of the cervical spine, you can have swimmer's view. And then this is a new one that I'm going to tell you today. It is called as pillar's view. Okay, because on MRIs you cannot appreciate facet joints. So if somebody has facet arthropathy, you will not be able to see on an AP and lateral. You have to have a pillar view. All right? And thank you for patience listening. And I'm sorry it was a kind of a presentation because it is so lengthy. I just wanted to cover everything. And if you have a curious mind, you will anyway find out what I'm talking about. Thank you.
Need a nice picture.